I just want to say thank you for the invitation to present today. That was a really impressive update on the project baseline from Ken, and it's just remarkable how much data is coming through there, and it's really, I'm really looking forward to seeing how that's analyzed and all the incredible insights that'll come out of it. My focus today is going to be a little bit more on the translation. I'm really passionate about the translation of, the validation of the data coming off smartphones, smart devices, and just the use of digital health in the clinical realm. So I'm going to share my focus is going to be on the opportunities in precision digital health. So I'll start with giving a little bit of background and why certain forces have come into play to kind of make digital health really an interesting area to implement all these insights we're gaining. And this isn't news to anybody listening today, but it's always important to highlight, we're spending in the US, a huge proportion of our GDP every year on healthcare, almost up to 4 trillion now. And this cost continues to go up. And despite this incredible spend, our outcomes are really not great compared to other developed nations. And this continues to be an issue. And COVID did not help to highlight, how poor our outcomes are. And then add to that the fact that we have an aging society. So that means a higher number of people with chronic conditions. And then add to that, again, that there aren't enough clinicians, or there won't be. They're predicted not to be enough clinicians to help manage all these patients, or all these people with chronic conditions. So really, when the government looks at issues such as this, any new solution that's being suggested or brought up or considered, that gets the government very excited, is any solution that meets the triple A, meaning, it not only improves patient outcomes, but it can do so at a lower cost and in a scalable fashion. So it's, less exciting to have a new device that's, super expensive and meets the needs of few people. And it turns out that digital health is really, really great at addressing this niche for certain areas, and what is digital health? Really, it's we think of it as the convergence of patient data, connectivity, and compute power to increase access and provide personalized healthcare to improve outcomes at a lower cost. And if you had to think of a framework, it's really straightforward. It all starts with a patient, all this data coming from the patient, as we heard from Project Baseline. And that data can come from, pharmacies, mobile devices, connected devices, lab results, and then is somehow analyzed either by a human or computers. And that analysis then provides, insights and information back to the health system, and ultimately benefiting the patient. This isn't new, the fact that this data kind of revolution that we're in is going to provide incredible opportunities. Eric Topol, has really popularized the concept of AI in healthcare, and how all the multi-omics can really come into play and really benefit the patient, potentially virtually. And so a lot of excitement there. The problem when it comes to translation in healthcare is that, we think of healthcare as kind of an 8-headed monster. There are so many different stakeholders. The payer is not the provider and is not the end customer. That's the patient. So it becomes incredibly difficult and challenging to innovate in the space and to have something that's sustainable. And then what digital health provides, which is really unique, is the patient, the connected patient, the patient in their home, which is another new dimension, which in the world of biodesign we've had to add as kind of a needs finding area. So I'm just going to highlight some, at a high level, some big enabling changes recently with kind of the background that was just presented. and kind of go into why digital health is a really interesting space. And I'll start with data. Peter Drucker, a famous consultant, would say, if you can't measure it, you can't improve it. And the same was very true for healthcare. Back when it was clear that the spending was going up and we couldn't really measure our outcomes, that's when government really said, if we need to digitize our records just so that we can analyze it and review it and see how to improve it. And so that's ultimately is one of the factors that led to the HITECH Act in 2009, where over 30 billion was spent on digitizing our healthcare system. It was kind of a carrot and stick model initially that was introduced, where health systems would get this funding, but in return would have to show that they're implementing these digital health records and implementing certain systems. The first stage of the meaningful use criteria, which was implemented, was very simple. Provide electronic order entry, provide a drug-drug interaction system. As time went on, it became clear that health systems were implementing. They were able to implement these systems, yet the data was staying within the health systems. It wasn't really breaking out of the health systems, and it was hard to access the data. So for meaningful use stage 2, they added a stipulation that health systems had, or 5% of the patients using the electronic health record had to be able to view, download, and transmit their own health information. And this was basically what became the patient portal for most health systems, and was really trying to highlight this idea that patients should become the stewards of their own health data. And really, if you think of it, it's kind of like the healthcare industry had its kind of SAP Oracle moment in 2009, when the original SAP Oracle moment, when the rest of the world had this moment in the 1970s. And it's a late start, but it was a start. And by 2016, about 96% of healthcare systems were using certified electronic health care systems. So that could be considered progress. However, as I kind of alluded to before, the issue remained that these data remain very siloed in each of the health systems. There's very little incentive to share the data or even make it available to patients. And so with this in mind, the government, with meaningful use stage 3, added this component that, for you to become certified, you not only need to be able to allow patients to view, download, and transmit data, that this needed to happen through an API. They didn't specify which API or anything like that, but it kind of laid the groundwork for what was to come. And one standard that you'll hear about a lot in health interoperability is this HL7 FHIR standard, or Fast Healthcare Interoperability Resources Standard, which is a modern web-based API tech stack, which makes it very easy to engage with. So in addition to that, they made it very clear by passing or publishing the Department of Health and Human Services that it is the legal right for patients to have access to their health records, and this needs to happen within 30 days of a request. That you can charge a nominal fee, but the patient can ask for it electronically. And so this was an important step as well. So the government was pushing, saying, hey, this data cannot remain siloed. It needs to be freed up. And so these are the kind of initial steps that kind of led to some early implementations of, for example, the Apple Health Record, which is a feature on the iPhone, which leverages this HL7 FHIR standard to get 13 elements from kind of participating health systems, such as Stanford or other health systems. And within literally minutes, using the hospital's login information, you can connect to the hospital health system and download on your phone, whether it's allergies, medications, lab values, things like that, using this HL7 FHIR. So these were the beginnings. of what's to come. They took it a step further and said, you know what, why shouldn't patients have access to their claims data? And so they took it a step further. And now if you, there's this project called Project Blue Button. And if you go log in as a Medicare participant, you can actually download all your health claims data and make it shareable. And there are a lot of health studies that are currently leveraging this API to kind of track to see if people are being compliant with medications and so on. So that was a huge amount of work done on the data side. Then you have the reimbursement changes, and most of the healthcare system in the U.S. is very much based on fee for service, meaning that we're very incentivized to fill the hospitals. Without a full hospital, you just can't stay open. It also rewards more and more procedures, and to bring healthcare to the expensive four walls of the hospital. So the government also realized that we need to, or policymakers, and realize that in order to manage costs and kind of realign the incentives to kind of think more to focus more on healthcare and preventative care, you needed new payment models to lower the cost. And the government is the biggest healthcare payer. 50% of healthcare is paid for by the government. And as an example, in 2018, almost 600 billion was spent on Medicare alone. And so we see these kind of new policies, such as MACRA, which passed in 2016, which offered or provided more quality payment programs to kind of reimburse or tie reimbursement to more quality metrics and outcome metrics. And you have these alternative payment programs, such as accountable care organizations, ACOs, and bundled payments for certain procedures, because it became clear to the government that it's a lot of these chronic conditions and patients with the chronic conditions that were driving up costs. They also expanded telehealth in 2018 with the Chronic Care Act, and also realized that in order to help prevent readmissions, for example, with someone with CHF, we may have to incentivize connecting with those patients in their home and catching things before they get too advanced, requiring an admission. So there's a program as well called Medicare Advantage, which is really Medicare, kind of a risk-bearing program or model that's administered by private insurers. And you can see that over the years, the Medicare Advantage enrollment has gone up. There's been quite a bit of uptick, and estimates are that by 2030, about 51% of all of Medicare will be through Medicare Advantage or at-risk models or programs. And one of the reasons they're becoming popular is that they get discounts on providing all these other more preventative type benefits or supplemental benefits at no extra cost, whether it's transportation, in-home support, fitness, dental, telehealth, things like that. Other models which have been really forward thinking, just because of the incentives, are integrated delivery networks such as the Kaisers and the Ochsner Healths out there, just because they're the payer and the provider for Kaiser. And for Ochsner, it would be more the fact that they have a lot of Medicare Advantage patients, have an incredibly successful remote hypertension program that has been very effective at reaching out or connecting with patients in their home and getting the blood pressures controlled much more quickly. I'm noticing that I do not have much more time. The self-insured employers have been really aggressive. They've been really bearing the brunt of a lot of these expenses. And the best story is always to hear that Starbucks pays more for their healthcare than they do for the coffee beans required to run their business. And so that's one example, but there's a lot of interest in using digital health and remote management for either care navigation or second opinions, such as Grand Rounds, to help lower costs and provide better patient experiences. And then you add to this whole mix COVID-19, which really has accelerated us in 5 months or 6 months, where everybody had predicted it would take us 5 years to get which has really pushed at least telemedicine, remote care up significantly.
Hi, Oliver. Sorry to interrupt, but do you have any closing thoughts? I'm sorry, we're at time, but
Is it time? Yeah, I'll just get to the end. So the bottom line is, I'll just have two slides or three slides. So, so the bottom line is, let's see that basically the opportunities are that we can, we can meet patients where they are, and it's much more, or these are the pressures, the drivers, so that instead of doing a procedure as prevention, we focus on prevention as prevention. And that really the patient is key to unlock the health data, right? We're moving towards a patient authorized data exchange. I think that's a key focus. So given the payment, reimbursement, and the regulatory changes, digital health is a great place to take all those insights you heard from Ken's talk on Project Baseline and to really transform it into a care delivery model specific to whatever you're focusing on. So that's it. I'm sorry to go so long. I didn't realize it would take so.
Oh, no worries at all, Oliver. Thank you so much for a great talk. I think, in a simple way, we can say, the health ecosystem is complicated. And so we understand it, certainly it's not something that can be covered in 15 minutes. But yeah, I think we talk about these things at length all the time. There's so many forces that you have to go through, on the innovation end, on reimbursement, on, getting into these clinical workflows. What advice do you have, for these new strategies? So there's so many things to take in, it's easy to get overwhelmed. You work with a lot of new inventors. What kind of tips do you give them to get started and kind of stay on the right track?
Yeah, I think especially if you're thinking about something that you really want to be translational, not research, but something that is implemented, in true by design form, you really have to make sure you're addressing a true pain point, a true need. And oftentimes, thinking of that business model, figuring out where your kind of solution is going to fit in is incredibly, incredibly important. And the people that I've seen be most successful don't build anything until they've got that figured out. And often they even have the first few customers lined up and figured out. And those are the ones, the solutions I've seen really, really work, and where the economics just really make sense. You got to make sure that incentives are there, because without those aligned incentives, it's really hard to gain traction for something, even though it's the right thing for patients.
Yeah, another question we have is, similar to the HL7 and the FHIR standards that you covered, I think, in your slides. Do you think it's useful or feasible to have standards for new data streams for, say, like wearables, omics?
Yeah, I think it makes a lot of sense. And unfortunately, the data standards for all the wearables are still being determined. And I know UCSF with, IDASIM, UCSF has a center for digital health, and they have published and are working on standards just as you described. And even if you wanted a full FHIR implementation, all the data elements or resources, as they're called, have not been fully agreed upon yet. So it's still a very nascent field, but standardization is key, is key to interoperability. And so as much as you can try to follow the standards, use the FHIR format as often as you can or wherever possible. I think that's critical. So you bring up a really important point.
Excellent. Okay, and I'll have one more question for you. I think, just for fun, what are you most excited about in the mobile health space? And I know you do a lot of work in this area, so I'm very curious. What gets you excited in the morning thinking about?
Yeah, I think that the 21st, I didn't get to it on that slide, but I'll talk about it now. But the 21st Century Cures Act, the final rule, which literally just came out, kind of mandated that all data elements be open via the FHIR API from all the electronic health records. that to me is incredible. That integration, that closed loop integration that helps us really not only make this pure consumer play, but also integrates the healthcare team, I think is going to have some really huge, impactful, meaningful effects. Now, it has to be in the right system where the incentives are aligned, where it makes sense for providers to connect to patients in the home and so on, to check on them. But I think that, just opening up the data through these standards is going to be, I think it's going to be incredible. So I see a lot of movement there already, and that really gets me excited and wants, that's why I'm trying to implement, as many of these kind of remote monitoring type engagements as possible.